Okay, so now let's delve deeper into the clinical features. So fatigue, medically unexplained, not relieved by rest, can worsen. We talked about it. We talked about post-exertional fatigue. You can see flu-like feelings can also occur. Normal activity or moderate exertion followed by worsening of malaise or intense fatigue. Sleep dysfunction, we talked about it, unrefreshing, difficulty falling asleep, middle insomnia, reverse sleep rhythm, and daytime hypersomnia. Autonomic manifestations, it also includes genitourinary alterations and GI as part of the autonomic nervous system. Sweating abnormalities. Pain, fibromyalgia is one of those things, but you can also have joint pain, tender lymph nodes, sore throats, abdominal pain, iron chest pain. And we know that many patients with chronic fatigue syndrome will give you a history of glandular fever. Now, there are a range of infections that have been associated with it as well, but generally EBV is one of those ones that are considered. But we'll see, of course, with long COVID, post-COVID is often, there's a clear temporality. You can see here brain fog. If you looked at all of this, you'd essentially end up with a diagnosis potentially of ADHD, but it's not just ADHD, and we'll see a case like that. Neuroendocrine manifestations, which also include thermostatic changes. You can see intolerance to heat and cold, sweating episodes, feeling of feverishness, cold extremities, significant relapse with stress. This is the overload phenomenon, anxiety or panic attacks. What I would suggest is think about this as hyperarousal and mesolimbic, what they call as overload phenomenon, and immune manifestations. So you can imagine when patients come with all of these symptoms, particularly when they don't get better, it can sometimes result in them ending up with a diagnosis of somatoform disorder. So although I've shown you what CFS is, what is the pathophysiology, but if I take a step back, and we know that we always come to the diagnostic hierarchy because this is what's going to help us the most. But broadly, let's recap. A couple of important points that we want to look at is, firstly, chronic fatigue syndrome. We look at the different constellations. We've looked at PEM. We've looked at fatigue. We've looked at cognition. I specifically look at mood dysregulation, but I think about it as emotional dysregulation. I ensure that the patient recognizes that this is not about labeling as bipolar or a specific psychiatric disorder, but rather the ability to regulate emotions that can be affected because cognition is affected. Next, sleep, absolutely crucial point. Then we have pain, which also we know includes allodynia or hyperalgesia. And then along with it, in between, there may be immunological, neuroendocrine, and autonomic nervous system dysfunction. So that's the constellation broadly, because sometimes we can get really lost with the details that they give us. But we want to know broadly, do they fall into this particular picture? In terms of pathophysiology and translation, this is the strategy. The key thing we know is that the fronto-striatal circuits are affected. So when we think about, this is linked to the ANS. Sleep is mediated through amygdala activation to a great extent. Sleep is mediated by prefrontal cortex inhibition on the amygdala. So sleep comes here. POTS comes here. Here we have hyperarousal as well. And then when we think about prefrontal cortex and striatum, in the prefrontal cortex, we have brain fog described in so many different ways. And this is where cognition comes in as well. In the striatum, we have fatigue. Now, in the striatum, you can have hyperactivity, but slowing down as well. So this is where amotivation, anhedonia, etc. can feed in. So now you have cognition. And note that the autonomic nervous system, the amygdala, these are closely linked to the HPA axis. So this is where neuroendocrine aspects come in. And we know that when HPA axis is involved, you're going to have inflammation. So what can we target? We can target this part through a serotonergic agent, reducing its hyperactivity in a way. But there are better ways of doing it. And this is where we know for sleep, there are alpha-2. Clonidine, prazosin, we'll see. We know we can strengthen this through the whole dopaminergic pathway, We have lower end of the spectrum antidepressants that increase dopamine, agomelatine, fluoxetine, vortioxetine. As we go higher up, we have NDRIs like bupropion. We have tricyclic antidepressants. We have tricyclic antidepressants that specifically increase noradrenaline, like nortriptyline. And then we have psychostimulants. We have psychostimulants that target orexin, like armodafinil, modafinil. And at the top end, we have Ritalin or methylphenidate, and we have dexamphetamines, short-acting, long-acting. So we know we can target this, and we can target this. And of course, there are going to be lots of other ways. You see, the autonomic nervous system, when we think about what physicians are looking at, they're looking at pyridostigmine, for example, because pyridostigmine is a cholinesterase inhibitor, increases acetylcholine, which we know mediates autonomic nervous system. We'll see midodrine, which is a sympathomimetic, which is again meant to activate the sympathetic drive. But note that the brain aspects are not often addressed adequately through, say, antihistamines, or through, say, famotidine, or through midodrine, or through fludrocortisone in POTS to increase vascular tone, for example. So you can see that the top down, the brain aspect is where we can get some big gains when our initial stages don't work.